Clinical reasoning, as defined by Pinnock and Welsh, is the ability to sort through a cluster of features and information presented by a patient and accurately assign a diagnostic label with the development of an appropriate treatment strategy as the end goal. Clinical reasoning is a vital part of all healthcare practitioners, including paramedics' daily work. At each job, the paramedic is taking a history from the patient, forming a differential diagnosis, and creating a treatment plan. This presentation will explore what clinical reasoning is, the current research behind teaching students clinical reasoning, and why it's important to improve clinical reasoning. I will also reflect on my own clinical reasoning and decision-making skills and how I hope to improve these in the future. As paramedicine becomes a registered health profession, there are now increased standards of patient safety and clinical excellence expected by AHPRA and the general public. There is limited research on clinical reasoning in paramedicine and the effects of poor reasoning processes on patients. However, there is extensive research into the clinical reasoning processes of doctors and nurses, which can be assumed to be similar to that in the pre-hospital environment. The most compelling evidence to support the need for improvement of clinical reasoning skills is found in studies on errors in clinical practice and mixed diagnoses. An audit of adverse events in Australian hospitals revealed that almost half of human error was caused by an error in cognitive function. This error includes the failure to elicit, synthesize, or act on the information presented to the healthcare practitioner. It has also been found that only 28% of graduate nurses met an acceptable score for the ability to recognise urgent changes or deterioration in a patient's condition and identify an appropriate response. The most common clinical reasoning theory is the dual processing theory. The dual processing theory is divided into either System 1 or System 2 reasoning processes. System 1 processing is fast, prudent, and often gets the right answer. System 1 involves an intuitive approach that is highly automatic and often occurs unconsciously. System 1 processing, however, is easily influenced consciously or subconsciously by a variety of factors. It is characterized by heuristics and mental shortcuts and is based heavily on pattern recognition or gestalt effects. System 1 processing is far more common in expert and experienced practitioners, however, it requires conscious reflection in order to reduce errors. System 2 processing is slower, more analytical, and resource intensive. System 2 requires conscious activation and utilizes semantic memory in the form of rules. These rules are used to arrive at a probability-based differential diagnosis or disease category that is causing the patient's signs and symptoms. System 2 utilizes deductive reasoning, typically in the form of if-then propositions. An example of this would be a patient presenting with chest pain. If the patient describes the pain as sharp, then it would be more probable that the pain was pleuritic in origin. System 2 processes become increasingly competent over time and are aided by maturity, formal education, and training in critical thinking. System 1 and 2 are not mutually exclusive and work in a dynamic relationship where either one can override the other. Cognitive error can occur if the practitioner relies too heavily on System 1 processes and fails to recognize that the patient presentation does not fit the established pattern. System 1 reflects the innate responsivity of the brain. However, through repetitive processing, System 2 can eventually lead to a System 1 response. In order to develop System 2 processing, novices should reflect on their own thinking, also known as metacognition, as well as compare and contrast several patient presentations in order to encapsulate their knowledge. During my own clinical placements throughout the degree, I have found the effectiveness and efficiency of my clinical reasoning skills to be one of the most challenging aspects. As a novice practitioner, my exposure to both typical and atypical patient presentations is limited. Clinical reasoning and decision-making takes significant time, experience, and cognizance to develop, much longer than the 720 hours we complete during the university degree. My mentors have given me feedback that whilst my rapport building is excellent and my management of typical low acuity patient presentations is improving, my management of high acuity, complex and or atypical patients still requires improvement. I have felt that this is where I've struggled the most during my placements, in that my clinical reasoning skills and therefore ability to respond to the sick or deteriorating patient is slow and does not meet expectations. Through discussions with my mentors, as well as feedback on my clinical assessment tools, I've discovered that I typically lean towards a System 2 approach in clinical reasoning. This is not uncommon in students, as System 1 reasoning relies heavily on experience and intuition, something that I am still developing. I have worked and will continue to work with my mentors to develop my intuition and ability to process multiple pieces of information at the same time. Throughout this assignment, I've also researched multiple ways to improve my clinical reasoning skills. The most effective way to teach clinical reasoning is for experienced practitioners to explain how and what they are thinking using the talk aloud technique whilst problem solving. The talk aloud technique is designed to represent cognitive task processes and give others an insight into the reasoning behind the practitioner's decision, but does not interfere with performance. The only concern regarding the talk aloud technique was raised in a study on pilots, which reported that verbalizing their decision processes can occasionally impact cognitive processing and increase errors in high workload environments. Watkins and colleagues suggest the use of an unpacking method, where a more detailed description of an implicit hypothesis generally increases its judged probability. This is where practitioners unpack a specific component of the presenting problem, such as chest pain, through focused questioning to develop a differential diagnosis. The unpacking method is also aided by the use of illness scripts. Illness scripts are an integral part of System 1 processing and typically are utilised unconsciously by practitioners when assessing and diagnosing patients. They typically include pathophysiology, epidemiology, and signs and symptoms, and are usually based on real patient experiences, hence why they are more commonly utilised by expert practitioners. An example of an illness script for an acute myocardial infarction could be male, over 50 years old, central crushing chest pain, diaphoresis, shortness of breath, and ST elevation on the ECG. Lee and colleagues undertook a study with undergraduate medical students utilising workshops and individual feedback for students to create their own illness scripts. This study yielded encouraging results for improving the students' performance in clinical reasoning processes. In the instance that a patient's presentation is atypical, the illness scripts may not fit perfectly, and the practitioner may have to revert to the System 2 process of hypothetical deductive reasoning or rapidly piece together the information to develop a new script. Modi and colleagues reported several different strategies to help teach clinical reasoning. These include exposure to a wide variety of patient presentations. System 1 processes are built on repeated exposure in order to develop pattern recognition. Students should be encouraged to utilise both System 1 and System 2 processes and should be asked what their intuitive differential diagnosis is early on, and then support them through systematic focus questioning. Modi and colleagues highlight case-based learning or case presentations as an integral part of developing students' clinical reasoning. During case presentations, there should be an emphasis on key features, links to the illness script fitting the disease, as well as repeatedly asking students for their differential diagnosis as more information is made available. One of the most important parts of developing clinical reasoning is deliberate practice. Deliberate practice is where repeated opportunities to develop skills are sought out, as well as requesting honest feedback, maximising learning, and reflecting on performance and feedback is undertaken by the student. As I continue my transition from undergraduate student to a novice practitioner, I plan to restructure my study plan. Pinnock and Welsh report that students typically organise their knowledge according to how the curriculum is structured. If the curriculum is structured by etiology of disease or organ systems, students store this knowledge in a way that is difficult to access when solving problems. If the curriculum is structured based on schemas, the knowledge is stored in an easily accessible and clinically relevant way. Schema-based learning has diagnoses grouped by relevant clinical and pathophysiologic variables and encourages forward reasoning. Through my research into schema-based learning and developing clinical reasoning skills, I now plan to structure my study based on schemas, as well as begin to develop illness scripts which will begin to further develop my System 1 reasoning processes. I also plan to undertake deliberate practice more often. I hope to utilise textbooks and online resources to undertake case-based learning, with a key emphasis on listing my differential diagnoses early and honing them in as more information is available, as well as utilising the cases to begin developing illness scripts. Reflective journaling has been shown to aid in the development of clinical reasoning skills in nurses. Through reflective journaling, students were able to have a positive impact on their analytical decision-making skills. They were able to identify similarities between their prior experiences and the novel situations presented to them, which allowed them to analyse the situation, piece together all of the information, and adapt quicker in the new situation. This reflective journaling could be beneficial to my development of System 1 reasoning skills, and I endeavour to investigate this if this would be a feasible option for myself as I begin my transition from student to graduate paramedic. To conclude, clinical reasoning is an integral part of paramedics' work and requires constant attention and continuing development. System 1 processing is more prominent in expert practitioners as the majority of skills occur subconsciously and rapidly due to experience. Novice practitioners depend more often on System 2 processing skills due to lack of experience, but through the use of illness scripts, deliberate practice, and schema-based learning can improve. I hope that as I begin to work as a practicing paramedic, that through repetitive System 2 processing, I can begin to develop System 1 responses, while also remaining cognizant and reflective of my own learning to reduce the risk of cognitive error.